Hi, I'm Kelly Howell. In this video, I'm going to talk to you about the key bony anatomy of the spine. The bony anatomy of the spine has three primary functions. First, the spinal bones provide a structural framework that allows for upright posture. Next, they are attachments for muscle tendons, enabling motions of the torso. And finally, they protect internal organs from injury. The spine and other bones are made up of two types of bone tissue, cortical and cancellous. Cortical bone is dense, hard bone. It makes up the outer shell of the vertebrae and the densest parts of the pedicles. Cancellous bone is soft, spongy bone, such as that found in the center of the vertebral bodies. Cancellous bone is more porous compared to cortical bone, with a honeycomb-like or trabecular appearance. Bone marrow rich in stem cells can be found in this type of bone. Now, as you learned in spine fundamentals, there are 7 cervical vertebrae. The first cervical vertebra, C1, is also known as Atlas, as in the Greek god who held the earth on his shoulders. And the second cervical vertebra, C2, is also known as Axis because it is a pivot point for rotation of the skull on the spine. The remaining cervical vertebrae, C3 through C7, are known as the subaxial region or below axis. Here's an axial view of C1. C1 is unique because it has no pedicles and no spinous process. It is a ring on which the occiput, or the skull, sits. C1 has a centrally located articular facet that articulates with the upwardly projecting dens, or axis, of C2, and the superior articular process that articulates with the occiput. C1 has laterally projecting transverse processes that serve as a connection point for various muscles and ligaments. The transverse foramen within the atlas provides a hole for the vertebral artery to run. All cervical vertebrae have a transverse foramen. However, the vertebral artery only runs inside C1 through C6, passing outside of the C7 transverse foramen. This is an anterior view of C2. Unlike C1, it has both lateral masses and pedicles. The odontoid process, commonly referred to as the dens, is an upward, thumb-like projection that articulates with the anterior articular process of the C1 ring as a pivot point. The combination of these two anatomical elements allows for axial rotation of the head. There's no disc present between C1 and C2. And the superior articular process of C2 articulates with the inferior articular process of C1. Together, they are referred to as a facet joint. Similarly, the inferior articular process of C2 articulates with the superior articular process of C3, and so on along the spine, making up all of the spinal facet joints. As previously mentioned, cervical vertebrae C3 through C7 are referred to as subaxial vertebrae. These vertebrae are more typical than C1 and C2, having a body, pedicles, transverse processes containing a transverse foramen, lamina, spinous processes, and facet joints. They share many of the same anatomical characteristics, with a few exceptions at C7. C7 typically does not have a split or bifid spinous process for tissue attachment. The vertebral artery also does not run inside the transverse foramen, but rather around it. In addition, the C7 pedicles and lateral masses are comparatively smaller than the other subaxial cervical vertebrae. This is relevant when using posterior fixation in the cervical spine, as surgeons may choose to skip C7 and fixate to T1 instead. Shown on this anterior view of the subaxial cervical vertebrae are the uncinate processes. The superior and inferior uncinate processes come together to form the uncovertebral joint. During an ACDF procedure, surgeons typically use the uncinate processes as the far lateral border for the decompression. The intervertebral foramen is where the exiting nerve root lies. The exiting nerve root travels along the sulcus of each level, which provides a smooth flooring support for the nerve as it exits the bony spine. This is a lateral view of the T1 through T12 thoracic vertebrae. Notice the kyphotic curvature of the thoracic spine and long spinous processes that overlie each other. Each vertebra has costal facets where the ribs attach. Because of the rib attachments, the thoracic spine is very stiff, as opposed to the cervical and lumbar spine, which are more mobile. Here is an axial view of a thoracic vertebra. Notice the heart-shaped vertebral body, the superior and transverse costal facets for rib attachment, and the elongated spinous process. In addition, the thoracic spine has small, narrow pedicles, making screw placement more difficult than in the lumbar spine, but not impossible. This image shows the rib cage with the thoracic spine. The T1 through T10 ribs attach anteriorly to the sternum. The T11 and T12 ribs do not have an anterior attachment and are referred to as floating ribs. Due to the rigidity of the thoracic spine, the transition zones from cervical to thoracic and thoracic to lumbar regions are prone to trauma-induced injury. An example would be a T12 or L1 burst fracture due to a traumatic fall or auto accident. This is a lateral view of the lumbar spine, L1 through L5. Notice the lordotic curvature of the lumbar region and horizontal square spinous processes. Because of the lumbar vertebra's location at the base of the spine, this region bears a majority of a person's upper body weight and is where much of the motion of the torso occurs, creating both load and strain on these segments. Here's an axial view of a lumbar vertebra. Notice the large kidney-shaped vertebral bodies and large, wide pedicles. Notice how the perimeter of the end plates is made up of dense cortical bone. This is known as the apophyseal ring or ring apophysis. Implants that are placed on and span the apophyseal ring have a lower risk of subsidence or sinking into the vertebral bodies above or below than those placed on the softer cancellous bone in the center. This is a posterior view of a lumbar vertebral motion segment. A motion segment is defined by two vertebral bodies with the intervertebral disc between. The anatomy here is very similar to what we have previously viewed. Let's now, though, point out the pars interarticularis, commonly referred to simply as the pars. The pars is a region or bridge of bone that connects the lamina to the pedicles. A pars defect would cause a discontinuity between the posterior elements of the spine and the vertebral body. Think of the pars as the portion of bone that connects the roof of the house to the walls. This is a posterior view of the sacrum and coccyx. As you learned in spine fundamentals, the sacrum is 5 fused vertebral segments, referred to as S1 through S5. The sacrum is largely made up of cancellous bone with a cortical shell and is wedged between the 2 iliac bones of the pelvis. It functions to transfer the axial load of the spine to the pelvis and legs. The coccyx is 4 small fused vertebrae at the end of the sacrum. It's commonly referred to as the tailbone and has no function. Here is a lateral view of the sacrum and coccyx. Notice the kyphotic curvature of the region as well as the sacral slope. The angulation of the sacral slope will have an effect on the amount of lordosis needed for a patient to be in proper spinal-pelvic alignment. The sacral promontory is also a commonly referenced anatomical feature of the sacrum. The bone close to the promontory can be more dense than the cancellous bone of the sacrum. For this reason, when placing S1 screws, surgeons may place them in a trajectory toward the promontory to achieve better bony purchase in their fixation. And that's it. Now you know about the key bony anatomy of the spine.